Good afternoon, everyone, and thank you for joining us today for our TIF Talk. Today, we have our special guest, Dr. Patrick Chiasson. He is a bariatric and foregut surgeon practicing in Tucson, Arizona. Welcome, Dr. Chiasson.
Thank you. Thank you for having me tonight. This is great, and I'm looking forward to it.
Fantastic. My name is Andrea Millers, and I'm with Endogastric Solutions, and we're very excited to have you here today to kind of talk about Gerd and the TIF procedure. If you guys have any questions throughout this event, it is live. I can see your questions come through, so please feel free to ask any questions in the question box or the chat box, if you will, for Dr. Chiasson, and we'll do our best to answer all of the questions that you have. So again, Dr. Chiasson, welcome, and let's go ahead and get started. Let's talk a little bit about what Gerd is and maybe give us an explanation of symptoms and what types of problems some patients could be finding their symptoms if they have Gerd.
Okay, great. So, first of all, Gerd is one of those terms that gets thrown around that lots of folks really don't understand. Most people, when they think about quote unquote Gerd, really what they're thinking about are heartburn-like symptoms. And what's important to know is that this is a really common problem. About 45% of American adults will take some antacid medicine about once a month, usually because they've had too much to eat or they were planning on going out and drinking too much, and so they maybe took a Pepcid C before they went out. So this is a very sort of common problem in our society. But it has a lot of different levels of severity, and what's more important to know is that about 10% of American adults actually take medicine for chronic heartburn or Gerd symptoms every day. And in the United States today, more than 20 million American adults are taking antacid medicine every day. This is a problem that's getting much worse in our society because of the increasing association with the association between heartburn symptoms and our rising weight. And what we're seeing as a result of this is more and more complications related to Gerd. So Gerd, there is a definition for it. It's called the Montreal definition. It's quite simple. It basically means that someone either has symptoms or changes in the lining of the lower esophagus caused by damage from acid coming into the esophagus, usually from the contents of the stomach, which are going into the esophagus. And this can be related either to the sphincter muscle, which separates the esophagus from the stomach, either being permanently injured, such as someone who has a hiatal hernia, or transiently decreased. And we know there's something called transient relaxations of this lower esophageal sphincter. And if people have a lot of those, they can have heartburn issues. As far as symptoms go, aside from the sort of classical heartburn symptom that we describe, one of the interesting things in my practice, if you ask people if they have heartburn, often people don't know what you're talking about. And there are lots of different symptoms that people have that all relate to these reflux of gastric contents. And they can range from chest discomfort or burning symptom. Some people describe indigestion. Some people have a sense of food coming up into their esophagus. Those are sort of some of the typical symptoms that people have. There are also a bunch of atypical symptoms that people have that can be related to Gerd. We call these the extraesophageal manifestations of Gerd. And these can be things like pulmonary symptoms like chronic cough, or most people don't know this, but about 50% of folks who have adult onset asthma will have heartburn or Gerd as a cause of that. People can have infections or pneumonias caused from reflux. And then even further up in the airways, we see a lot of patients who have chronic hoarseness, laryngitis, frequent throat clearing, those kinds of symptoms that can be associated with reflux of gastric contents all the way up into their throats. There's lots of different symptoms that people can have as a result of having reflux disease.
Perfect. Thank you for the explanation. It's great. Can you describe a little bit what are the treatment options, or actually how do you normally talk to patients about managing their GERD symptoms?
So I think that there's different levels when you start talking about a condition like GERD. So as a surgeon, most people that are coming to see me are people that, at least subjectively, have been diagnosed with GERD. And so for people that have sort of mild symptoms, these are the folks that typically are told to avoid certain foods, things like chocolate or coffee or alcohol. They may be told to avoid spicy foods or things that have onions or tomatoes. Basically all the things that we like to eat, we're told to avoid, which makes it a little bit complicated.
Right.
And the reality is that if you have sort of mild symptoms, that often dietary changes can make a difference in terms of how you do. But folks that I generally see who are at a point where they're taking chronic medicine and have, fairly significant symptoms, those folks, usually the diet modification pathway is one that they progress beyond, and now they're into the phase where they're, taking regular medicines to manage their. So we can talk about medicine in a second. As a surgeon, I think it's really important that we focus on the idea of having objective ways of diagnosing gastroesophageal reflux disease. There's a guy named Dr. Pandolfino in Chicago who's done some interesting work looking at people that take antacid medicine for presumed GERD, and has found out that about 40% of folks that take medicine for GERD actually don't have severe GERD. So I think it's really important that when patients are coming to talk to their surgeon about surgery, that they understand that it's important from our point of view that we're able to sort of make an objective diagnosis of their condition that's not just based on the symptoms that they have, but on basically physiological criteria that we use to make this diagnosis.
Yeah.
So I'll talk about that a little bit more as we go on. So why don't you carry on with your questions?
So let's actually talk about that right now. That's a question we get a lot from patients is, what types of tests or diagnostic tests do I need to have to, understand if they actually do have GERD, and then B, are they candidates for these types of procedures, whether it's the TIF procedure, the Nissen procedure. So maybe you can talk a little bit about the workup or the types of diagnostic tests that you guys would normally do.
So the workups for patients with gastroesophageal reflux are sort of evidence driven, and every patient, from my point of view, who is being considered for an anti-reflux procedure, whether it be the TIF procedure or others that you mentioned, should have an objective test where we confirm the diagnosis of GERD. So there's something called the Bravo pH test, which is the simplest test to do, where at the time of an endoscopy, we'll leave a small probe in the lower esophagus, which measures acid exposure in the esophagus. And this is particularly important for those individuals who don't have any visual signs of severe reflux disease. There are many folks who take chronic antacid medicine, and when we look in the esophagus, we don't find any of the complications of the reflux that would confirm the diagnosis. So the Bravo test, typically in patients who have a classic history of GERD, we do for about 48 hours. This probe is placed in the esophagus. You wear a receiver on your belt, and all the information for acid exposure is transmitted to that receiver. And that enables us to know what the total time of acid exposure is in the esophagus, as well as also allows us to look at the correlation between acid exposure and the symptoms that people are having, because there are 3 buttons on the receiver that you can press when you have a cough, when you're having heartburn, when you're having regurgitation. And I think that's really reassuring to patients that they actually can see visually that when they are having a symptom, that's when they're having acid exposure. And I think it's reassuring to them in terms of understanding that the problem that they have is real. So that's we do that for our patients who have classic heartburn symptoms. There's a subgroup of patients that are important to know about, and those are people that have something called silent reflux, which can be manifested with these proximal symptoms in the throat. So there's a term for it called LPR, or laryngopharyngeal reflux. And these are folks that will often present with sore throat or laryngitis or hoarseness, and they don't give necessarily a history of severe heartburn, and they can be a little bit more complicated to diagnose. In our practice, we do the Bravo test for 96 hours instead of 48 hours as a preliminary test, because by adding the time, we increase the diagnostic yield. The interesting thing about these patients is often they don't have severe reflux in terms of our acid exposure testing, but they have these chronic symptoms. And what we've come to understand is that you don't necessarily have to have acid reflux in the throat to cause symptoms. You can have non-acid reflux in the throat, and you only have to have a couple of episodes a week to have chronic symptoms. So as a primary diagnostic tool, we do this Bravo pH testing. As a secondary diagnostic tool, folks that have these LPR presentations, we do something called 24-hour Ph Impedance Testing. It's a very sophisticated name, but basically we're looking for gastric contents to come up into the proximal throat, and it can be acid or non-acid. And if you have a certain number of episodes, that can be diagnostic as well for that problem. And we understand that if we can make the diagnosis, then we're in a much better position to help people manage those symptoms. And I'll talk about that more as we go along.
Okay, thank you.
The other couple of tests that get done in general, most everybody who is going to have anti-reflux surgery, from my point of view, should have something called high-resolution esophageal manometry. And this is usually a test that we do after we confirm the diagnosis of GERD. And in this, because this test is a little bit more complicated because it's not the most pleasant test, but we'll place a probe through the nose into the stomach. It takes about 15 minutes. The nurse will have you swallow 10 sips of water. And then this enables us to see how well the esophagus is functioning. And it helps in terms of how we, quote unquote, personalize our care. And depending upon the surgeon you see, they may offer different surgical options for patients based on the characteristics that the patient has in terms of their esophageal function, the size of their hernia, the severity of their reflux, those kinds of things. And then occasionally, in certain patients, we'll do something called the gastric emptying test, and that's to exclude a condition called gastroparesis, which can cause reflux symptoms and also can be associated with poor outcomes after anti-reflux surgery if it's not diagnosed and discussed prior to going ahead with surgery. So in my practice, I like to cover all my bases and do a comprehensive workup. And that enables me to then talk to the patients about the different options that are out there surgically and what might be best suited for that individual.
That's perfect. Thank you. So let's talk a little bit about the treatment options that are currently available for GERD. So I know you talked about patients taking medications, whether they're PPIs, then obviously the surgical option. So do you want to kind of go through a discussion about the PPIs and then the different types of procedures that are available?
Certainly, over the years, there's been an evolution in terms of the medical management options that patients have. Initially it was the introduction of Tagamet back in the 1970s that sort of changed everything as far as medical management for reflux disease. And the H2 blockers certainly have or histamine channel blockers certainly have their role to play in people that have mild or moderate heartburn symptoms. And for those medicines I'm talking about are famotidine or cimetidine. Ranitidine has been taken off the market more recently. But for those individuals who have severe GERD or daily heartburn symptoms or complications of GERD like Barrett's esophagus or esophagitis or esophageal strictures, those individuals typically will need to take a more aggressive medicine. And so the proton pump inhibitors are really the medicines du jour that we use as a first line for those individuals. There's lots of different proton pump inhibitors out there. I won't go into each one of them. People are familiar with the purple pill because it was advertised so well. But the long and the short of it is that for people that have, severe GERD, typically these are the 20 million Americans that are taking medicine every day. And the thing about proton pump inhibitors is back in the early medicines, they were handed out, they were given or prescribed very commonly. And there wasn't much concern about possible side effects related to these drugs. And I think that one of the things that's become really evident in the last couple of years in the literature is that these medicines do have potential side effects associated with them. And that's one issue in particular. First, there's some people who can't take them because they're allergic to them. There's some people that get side effects from them, such as diarrhea, and they can't take them. But there are also individuals who develop other medical issues as a result of taking those. So for instance, one of the number one sources of referrals that I get are from the nephrologists who have patients who've been taking these medicines for many years and are having worsening kidney function and are being told they need to stop these medicines. And they don't really have it, so now they're looking at surgical solutions to address the fact that they can't take proton pump inhibitors. We know there's an association with hip fractures in postmenopausal women. There's some sort of loose epidemiological data suggesting a relationship with dementia and long-term PPI use. There are a lot of concerns that are out there that are making patients anxious about taking these medicines.
Right.
The other thing that's really important to know about proton pump inhibitors is that they don't always work for everybody. And this is one of the big reasons, again, why surgery is becoming more important, is because we now understand that about 60% of folks that take proton pump inhibitors to manage their heartburn symptoms are adequately controlled as far as their symptoms go. The problem is that about 40% of folks that take these medicines have inadequate control of their symptoms, and they have what we call breakthrough symptoms. So they're needing to take additional medicine, or they take over-the-counter medicines, or they carry Tums or Rolaids in their pockets because they're getting these other symptoms. And the question then becomes, at what point do we start thinking that maybe medicine by itself is not the answer to addressing someone's heartburn issues? And so that's where the role of surgery comes into play.
Right.
As far as surgical options go, the way that I talk about the surgery options is I talk about the old guard treatment options and then the sort of newer, what I would just say are more modern treatment options that exist. And I think TIF sort of falls into that category. So as far as the old guard treatment options, there's a procedure called the Nissen Fundoplication that was done before the advent of minimally invasive surgery as an open procedure. This was developed in the 1950s, and we would take the top of the stomach and we would wrap it around the lower esophagus as a way of augmenting or strengthening the sphincter mechanism that separated the esophagus from the stomach. And that's an operation that, when it was the only one out there, was tried and true. But the reality is that there was a lot of variability in terms of outcomes with that operation. There were questions about the durability of that procedure in terms of keeping people free of symptoms for a long time. And then there were side effects from that procedure, something called Bloat Syndrome, which is about common to about 50% of patients who have the Nissen Fundoplication. With the introduction of laparoscopic surgery in the 1990s, before the advent of proton pump inhibitors, the laparoscopic Nissen Fundoplication became relatively popular as an operation. And then with the PPIs coming on board, it sort of waned in, and I think in large part because it's a relatively difficult operation performed technically. It was not an operation that all surgeons learned to do well. And as a consequence, there was a lot of variability in terms of outcomes. And so it fell into disfavor. One, because of, I think, the lack of predictability and the fact that there were, fairly significant symptoms related to it. And these symptoms are really related to the fact that the Nissen creates sort of a one-way valve. There was a second operation that sort of falls in this category as well. It's called the Toupee Fundoplication. This is a partial wrap, not completely wrapping the stomach around the esophagus. This operation gained more favorability in the sort of 1990s and early 2000s. And there's been some concern that it wasn't as effective as the Nissen Fundoplication. I think that there's been some recent data to suggest out of Sweden that probably there's not much difference between the two operations. The presumption is that with the Toupee procedure, with this partial wrap, there's less of the gas bloat symptoms, although it's not entirely true that it goes away completely. Things that's true about the Toupee is that it enables patients to sort of belch a little bit more easily. In patients who have poor function of the esophagus in terms of pushing things through, it's an operation that's used in large part for those types of patients. The more recent operations that are available that people might be interested in, there's the two procedures that are out there. One is called the LINX, magnetic augmentation of the lower esophageal sphincter, and it's an operation that I perform in my practice. I'm not going to address it in much detail today, other than to suggest that it's an operation that has been available for about 10 years. And it's a procedure, that's been available for about 10 years. And certainly if patients came to me in the office, I'd talk about them more. And then there's the TIF procedure, which we're here to talk about today. So the TIF procedure, or the other term for it is transoral incisionless fundoplication. This is a procedure that was approved by the FDA in the United States, I think about 2007. I actually was the first surgeon in Arizona to perform this procedure back in 2009. And at that time, I did a number of cases. There were some issues as far as getting paid. I think it was a little bit complicated. The initial device that was used was an older device and was a little bit more cumbersome to use. So for various reasons, it fell out of my practice up until recently. And I started doing these again now. There's a newer device called the Esophagus 2. I think that there's good published outcomes suggesting that there's good long-term effects with the TIF procedure. And with this new device, I think it's a much more robust procedure than it was. And I think it's, from my point of view, very exciting to be able to offer this to patients.
Wonderful. Beautiful. So we've got a ton of questions that have come through while you were speaking. So if you don't mind, I'm going to ask some of the questions from the patients or from the people watching.
Great.
Yeah, wonderful. So Valerie's first, she says, good evening and thank you for doing this. She would like to know, what would you consider the cutoff Demeester score to qualify for surgery?
So that's a good question. So the Demeester score cutoff for the diagnosis of severe GERD is 14.7. That's the standard cutoff score. There are patients who fall into the category where they're around that score. We may see that there's 100% correlation with their cough symptoms and acid exposure. Especially for these patients that have more proximal symptoms, if I see that they have strong correlation, we may advise to do a second evaluation to look for a confirming diagnosis of LPR. If someone has a moderate to large size hiatal hernia, a borderline Demeester score, and good symptom association, it really all depends on all the individual circumstances of that patient. Then that patient probably well served with anti-reflux surgery. I think that's an important consideration. The other thing that gets missed a lot is that, the Demeester score is an average score of the time during which we're doing the testing. Mm-hmm. And so one of the reasons why in my LPR patients we do 96 hours of testing is it increases the diagnostic yield by about 20%. And you only have to have 1 day's worth of by definition, severe GERD to qualify. It's not based on the average score over the period of time. And so I think there's a lot of detail that you can get out of a Bravo pH evaluation. And I think it's really important that based on your symptom presentation, that we're doing the right length of time when we do the testing, because I think that, I really do believe that you can benefit patients a lot with these types of approaches. And so I think our goal should be to increase our diagnostic yield as opposed to excluding patients from having these procedures if they're not quite there with respect to the testing.
Perfect. Thank you very much. So we've got another question from Latanya. She's asked, or she's actually stating a couple of things. She's got most of the symptoms that you discussed. She says she feels it in her nose sometimes and can smell it. She's also vegan and not able to have tomatoes, onions, avocados, olive oil, probably a bunch of different things. And she's struggling with GERD every day. So she says she has silent GERD, and she's asking what insurance covers this procedure.
So again, insurances are fickle, and so it behooves us as surgeons that we, again, obtain very good objective information in terms of confirming a diagnosis, because at the end of the day, the insurance companies are really looking for that objective information to be willing to pay for anti-reflux surgery. And I think it goes more than that. The other thing is that, we've been down the road in the surgical business of operating on people with subjective diagnoses based on subjective symptoms, and the outcomes are never as good. And the thing that's true about surgery is that everything that we do ostensibly is permanent, and so we really want to have the best information that we can in terms of making a diagnosis before we start talking about procedures that carry risk and are permanent solutions to the problem.
Yeah, it's a very good point. Thank you. So, you did mention earlier, I think in the last question, and we haven't talked about it yet, but hiatal hernia. Can you describe what that is and how does that correlate, or does it correlate to someone that is having GERD symptoms?
So, a hiatal hernia is basic. So just to take a step back. So the hiatus is a natural opening between the chest and the abdomen, okay? And there are two structures that pass through the hiatus. At the bottom of the hiatus is the aorta, which is the main blood vessel that brings blood to the lower half of the body. And in the upper part of the hiatus is the esophagus, okay? And in any area in the body where there's a natural weakness, there's the potential for herniation or structures pushing through that area. So in the abdomen, this is an area of positive pressure. We all are sort of packed into our belly, for want of a better description. And so there's generally pressure on those areas of natural weakness. So the hiatus being one, umbilical hernias are very common because another natural area of weakness. In men, inguinal hernias are common because, again, that's a natural area of weakness. So with respect to hiatal hernias, we know that about 15% of the adult population has a hiatal hernia. And we also know that the heavier you are, the more likely you are to develop a hiatal hernia. So, I'm a weight loss surgeon as well. I used to say I practice bariatric surgery. So I see a lot of people that are overweight and very heavy. And amongst people that have a BMI over 35, which is sort of our cutoff definition for class 2 obesity, we know that about 30% of those individuals who have hiatal hernias. Now, it's really important to understand that hiatal hernias are not all created equally. There's actually 4 different types of hiatal hernias, the most common of which is something called a type 1 hiatal hernia, and it applies most to this conversation. And that's a hernia where less than half of the stomach is herniating through the defect up into the chest, okay? Type 2 hernias are rare. You don't need to know about that. Type 3 hiatal hernias are where more than 50% of the stomach is going up into the chest. And that's sort of a different category of patient. We often operate on those patients not for heartburn symptoms, but for other issues. And then type 4 are the biggest hernias. So I'll just take a step back. So hiatal hernias are interesting because not everybody who has a hiatal hernia has GERD, okay? Because at the end of the day, if that sphincter is strong enough, it can keep the contents of the stomach in the stomach and not have them go up in the esophagus. What we understand, though, is that for people that have reflux symptoms or gastroesophageal reflux disease, if you have a hiatal hernia, there's a good chance it will worsen your symptoms. So there's a correlation with worsening gastroesophageal reflux symptoms if patients have hiatal hernias. So if that makes sense to the person who asked the question. So one of the things that's true about our practice is that the majority of the patients that I operate on for severe GERD are patients who have hiatal hernias. That being said, there's a significant number of folks who have reflux disease who don't have hiatal hernias, and to me, that's the population where the TIF procedure really adds a lot of benefit for those patients, because the TIF procedure, as I said, stands for a transoral incisionless fundoplication. So this is an endoscopic procedure that we actually do when we go through the patient's mouth into their stomach and reconstruct the valve separating the stomach from the esophagus from the inside out. And so as a result of that, patients have a procedure. There are no scars. There's no incisions. There's no scars. I won't say that there's absolutely no pain. These patients will often experience a bit of throat discomfort because it's a large device that we place down through the throat. There may be a bit of shoulder tip discomfort. But in my practice, I send these patients home right after the procedure, and patients do fine. Usually within 24 to 48 hours, they take just Tylenol for discomfort, and I've had frankly no unhappy customers. They're quite happy to go home after the procedure instead of staying in the hospital overnight. So I think that it's one of the things that I think is really exciting, because we have this ability to offer this procedure to those individuals who have GERD, who don't have significant hiatal hernias. As far as the patients who have hiatal hernias, that have type 1 hiatal hernias, the TIF procedure has been approved as a concomitant procedure since the mid 2015-16 range. There's been a CPT code with Medicare for doing a combined hiatal hernia and transoral fundoplication. So since 2017, so you can have a transoral fundoplication with a hiatal hernia repair. The repair is done laparoscopically, and then the transoral fundoplication, which is a partial wrap, can be done at the same time, either in my practice by myself doing both procedures, or in many practices now, a combination of the gastroenterologist working with the surgeon.
Okay, thank you. Appreciate that. So, and the next question from Tara: how do you know if it's, she's quote unquote severe GERD? Her husband has been diagnosed with GERD, but just started taking PPIs, not prescribed, so self-prescribed, and he only takes it when it hurts. So she's kind of wondering, when do I know it's pretty much that, when do I take that next step, if you will, for him?
So, I made the comment earlier that many folks take medicine for GERD, and it may not necessarily be GERD. So that's the first comment that I would make. The second comment, and I really believe this, is that anybody who is taking a proton pump inhibitor for presumed GERD should have a evaluation and objective evidence that they truly have severe GERD. I think that with the side effect profile now with PPIs, that we have to be concerned about this. And obviously this is a controversial point of view. It's a personal point of view that I have, and quite frankly, given the fact that these medicines are being sold over the counter, not everybody's sharing this point of view. The truth of the matter is that though, if you look at the box on the over-the-counter box, it says very specifically this medicine should only be taken for 14 days. And if you continue to have symptoms afterwards, you should seek the evaluation of a physician. The first point. Second point is, is that anybody who has new upper GI symptoms who's age group 50 or greater should have an endoscopic evaluation. That's standard of care, because what's really a problem is if patients are taking medicine to mask symptoms, which may be related, for instance, to gastric cancer or a gastric ulcer or esophageal cancer or something that's quite significant, and they're delaying their seeking medical counsel because they can take these over-the-counter medicines, that's obviously problematic. And I would probably fall into the camp of individual who would tell you that I don't think any PPI should be over-the-counter. I think they should all be prescribed only for the reasons which I just said. Now, again, that's a controversial point of view. With respect to the question that was asked in this individual's husband, it's really important that if you're going to take, if you're prescribed PPIs, you take them every day. These are not medicines that are fast acting. These are medicines that typically take about 24 to 48 hours to achieve maximal strength, and they're medicines that are not intended to be sort of taken on an ad hoc basis. And so what I would counsel that individual is to suggest to her husband that if this is the medicine that he feels he needs to take, maybe he needs to talk to his doctor about it.
Right. So because you're a surgeon, and let's say she just mentioned that his GI did prescribe the medication, but he was only taking it when he felt like he needed it. So because you're a surgeon, how does a patient get referred to you, or can they self-refer to you, knowing that they've been suffering with these symptoms, they've already been prescribed PPIs? They just contact you, or would they have to get a referral?
So, part of that depends on their insurance.
Sure.
And so what I would tell you is that my practice is somewhat unique, maybe because I'm a Canadian trained doc, and endoscopy was sort of part and parcel with what I did in my training and when I came to the United States. So my practice is comprehensive, both diagnostically as well as in terms of the procedures that I perform. And I tend to do all the evaluations myself in terms of Bravo pH testing. I do my own manometry evaluation. And as a consequence of that, I find that very enabling for patients. It's one-stop shopping. They can come in, are evaluated. We go over all the test results. There are no intermediate steps. They don't have to go see other people in order to come and talk to me and get the care that they need. That doesn't mean that I operate on every patient that I see, but what it means is that folks can maybe avoid sometimes frustration with steps that are not helping them reach their goals as far as being evaluated.
Yeah, that's great. Wonderful. Someone's asking, Doctor, this is Sabrina, I have a hiatal hernia. My worst symptom is extreme pain in my esophagus and trouble swallowing. Can you explain how GERD results in esophageal pain?
So that's a good question. So there are sort of two categories of people that have what we call adynophagia or esophageal spasm. So in patients who don't take antacid medicines and they have a hiatal hernia, maybe they have intermittent symptoms. Maybe if you go out and eat too much or have a couple extra cocktails, and you get a large bolus of food and acid come up in your esophagus, the lining of the esophagus doesn't always like being exposed to acid, and it can cause discomfort. The other comment that I would make is that one of the interesting things that we know about folks is that there's a large variability in how sensitive people are to acid reflux. There are folks who have severe reflux disease and have very limited symptoms, and then there are other folks who have minimal acid reflux who have maximal symptoms when they get acid in their esophagus. The other comment that I would make is that for patients who have these large type 3 paraesophageal hernias that I described earlier, one of the characteristic findings in those individuals are having atypical chest pain when they eat. If the stomach is folding in the chest when they're eating, you can get severe chest discomfort, which will feel like esophageal spasm or atypical chest pain. These patients often will see the cardiologist before they see a gastroenterologist or me, because to make sure they're not having heart issues. That can be caused from folding of the stomach. The other thing that happens when the stomach folds is that it makes it hard to swallow. Food doesn't want to go down very well. So for patients who have a lot of difficulty swallowing, this atypical chest pain presentation, especially if you're an older person, particularly women more than men, often this is the harbinger of a type 3 paraesophageal hernia.
Okay, thank you. Another question, what is the TIF recovery like? Will I be out a long time?
So this is a great thing about the TIF procedure from my point of view, is that, I do these procedures on patients. It's hard, everybody's different in this regard. So I tell them that, they should plan on being off work maximum a week. And I have patients who are back fairly normal activities, 24, 48 hours after their procedure. Some patients take longer. It's really sort of an individual thing. The nice thing about not having incisions is that you can go back to fairly normal activities. My restrictions are I tell people no jogging or horseback riding for 2 weeks after the procedure. Those are the things that increase your intra-abdominal pressure the most, believe it or not.
You can tell you're in Arizona.
Yeah, that's absolutely an Arizona recommendation, because early in my practice here, I had a couple of cowboys I operated on, and they'd call me after they'd been out on their horse and tell me they were hurting, and so I told them they needed to back off. And then I tell people no for a month after procedures, but certainly if you're a golfer, you can start swinging a golf club within a week. Tell people to swing easy. That's advice I give to every golfer. It makes their game better. But in general, people get back to fairly normal activities fairly quickly after these procedures, especially if we don't do a hiatal hernia repair. The recommendations change a little bit if we do the hernia repair, but for the straight TIF, you can get back to pretty well normal activities very quickly.
Fantastic. Can you talk a little bit about the diet? We got a lot of patients that come on asking, what's the diet going to be like? Am I just going to be drinking liquids for 6 weeks or whatnot? What's your protocol for the post-op diet?
So I think it's important when we talk about the diet to understand how the procedure works. Okay, so just so for the viewer. The way this procedure works basically is we pass the device into the mouth, into the stomach, and then we look back up at the junction of the esophagus and the stomach, okay? And the goal with the procedure is to recreate a normal valve, okay? And the valve is, for the most part, about 270 degrees. And what we do is we basically place sutures, or what are called H fasteners, at the corners of the valve initially, and then at the middle of the valve to finish the procedure. And these are not sort of typical sutures in the sense that we put a stitch through and we tie a knot. We put a lot of these fasteners, and they go between the wall of the stomach and the wall of the esophagus to bring the two together. And they have a little pledget on each end, so they look like an H, sort of a wide H. And so by putting a lot of sutures there, we pull the stomach and the esophagus together for about 3 to 4 centimeters. And then over time, as the two are posed together because of the inflammation from the procedure, you end up getting what we call serosal apposition, or healing, so that they stick together. And so if you start eating too quickly after the procedure, or for instance, if you eat too much and you vomit, or if you do anything potentially to cause a significant increase in pressure in the stomach, you have the potential to pull the stomach and the esophagus apart where we've placed those fasteners. Mm-hmm. So the focus of the diet really is to try and minimize any harm that you can do as an individual to the healing phase after this procedure. So this is a little bit unique to the TIF procedure. For the first 2 weeks, it's really a liquid type diet. And then after 2 weeks, then we start introducing soft foods, but small amounts. We recommend 5 or 6 small soft meals a day for another couple weeks. And then for the final 2 weeks, we start advancing the diet. Because by 6 weeks, the assumption is that the tissues are going to be well healed together, and it's going to be hard to disrupt anything by any dietary indiscretions.
Thank you. We have another, because you were talking about the fasteners, another question came up about the fasteners. What's the most fasteners you've used on a patient?
So with this new device, the minimum is 20. I would say that my average is about 24 to 26. For whatever reasons, I always want to reinforce the corners after I've done the procedure, but I typically don't place any more than that.
Okay.
There is a point where you can get Prolene Poisoning, I call it, where if you place too many fasteners, you're really just placing them on top of each other, and you're not really helping anything. In fact, I think you're potentially going to cause problems. So I think you have to be judicious. You have to look at the repair once you've completed it, typically with the initial protocol of 20 fasteners, and then look at how things look and maybe tidy things up a little bit with a few more sutures. But that's usually all you need to do.
Perfect. Thank you. One last question, I believe here. Din is asking, I've heard that anxiety makes symptoms worse. How true is that? And how do we go around treating this? I'm scared of getting addicted to some of these anxiety meds.
So, this is a great question. I think it's, I'll tell you a story about a patient of mine, because I think this might be the end. So I've got a guy in my practice who I did this TIF procedure on relatively recently. I won't mention his name, obviously. And he's someone who, by his own admission, has a lot of anxiety, and to me, taking maximal doses of antacid medicines and not being able to sleep laying flat, sitting up. And because of a lot of his overlay of anxiety and other medical issues, he'd seen a number of gastroenterologists who really had just sort of not taken his symptoms seriously. And so my philosophy of care in particular with this individual is I said, look, let's find out, first of all, if you have severe reflux. You're taking all these medicines. What you don't want to be doing is taking medicines you don't need. So, we did our Bravo pH evaluation, and lo and behold, his Demeester score was 40. Okay. And so we went on to complete his testing, and then we talked about his options. Now, during that time, he went and got another second opinion from another gastroenterologist who pulled me aside and said, this guy's crazy. You shouldn't be doing his anti-reflux surgery. And what I said to that gastroenterologist, who I talked to the patient about, is I said, look, I can't make all of your other issues go away, okay? But what I can potentially do is help you with this problem so it no longer will be a source of anxiety for you. And to that end, it might actually help you in an overall way in terms of managing your life. So we carried forward with treatment based on that sort of care philosophy. He had the TIF procedure, and I would tell you that he's 4 months now after his procedure. He was taking Dexilant and Nexium and a H2 blocker every day, as well as Gaviscon, and sleeping sitting up. Today, he's off all of his antacid medicines, and he sleeps with one pillow. And that's not to say he's not a nervous Nelly, anxious guy. Right. But the one thing he's not anxious about anymore is his gastroesophageal reflux disease.
Oh, that's fantastic.
So I think it's a great story. I think that, we as physicians are often guilty of ascribing too many symptoms that people have to their sort of underlying psychological states. And I think it's always important to remember that having a functional condition or a psychological condition is always a diagnosis of exclusion after we've made sure that there's not something more physiological or anatomic that's going on. So,
right. That's a great story. Thank you for sharing that. During these times with COVID and people with high stress, I think I hear a lot of patients say, my symptoms are way worse because I'm stressed all the time. I don't, so I think that's a very good point, and I'm glad you shared that story with us. There was a follow-up question, but I think you kind of answered it, but you may want to speak or elaborate to it. The question was, are most of your patients able to get off of PPI medications post-TIF? And so you had said for this particular patient that he is off most of or all of his PPIs, but is that similar for all of your patients?
So, I wish I could tell you that every procedure is perfect and we stop all the problems. The reality is that when it comes to anti-reflux surgery, this is an operation where we're trying to improve function. It's not like taking out a gallbladder where once the gallbladder is gone, it's gone forever. Our goal really is to make someone's anatomy work better, okay? And so the outcomes with anti-reflux procedures, and this goes beyond TIF, it goes to the Nissen, the Toupee, the Lynx procedure, to a large degree is based on that individual's circumstances, what their weight is. We know that there are weight cutoffs for all these procedures in terms of effectiveness. It depends on the size of their hernia, potentially. It depends on their lower esophageal sphincter pressures that we can augment. If you look at what's published for the TIF procedure, what I would tell you is that based on 5-year outcome data, that about 65 to 70% of patients are off all of their medicines with the TIF procedure, and that about 80 to 85% of folks, including that 65, are taking decreased medicines. So there are very few patients who don't have an improvement in their condition. And this goes to why it's so important to be testing these individuals beforehand, because if we don't know what's really going on, and then we do a procedure and then patients don't get better, it's really hard to understand what we've done for those individuals. And one of the nice things about the TIF procedure, there's a great paper that was published out of the Netherlands back in 2014, where they actually looked at multimodal evaluations of these patients doing some of the tests I talked about earlier, something called Ph Impedance. They did something called endoflip, measuring the pressure that's generated in the lower esophageal sphincter. They looked at this transient lower esophageal relaxations. And we have some good physiological evidence that the TIF procedure actually changes the function of the lower esophageal sphincter significantly, so that it's not just imagination, us doing these procedures. They actually help resolve the problems of the lower esophageal sphincter in terms of stopping reflux from going from the stomach into the esophagus. So, I tell all my patients, if you eat 3 Big Macs and lay on your stomach and go to bed, you're going to have heartburn. I don't care what operation I do, okay? That's just the bottom line. You have to be smart about the way you live your life, and people make adjustments to the, in terms of how they eat and how they live their lives that will coincide with having had the procedures done to yield the best outcomes. And I think that's an important way of thinking about how we improve these conditions.
Perfectly said. Thank you. So that's about all the questions that we have tonight. Is there anything else that you wanted to add, or you've given us some really great information and some scientific backup of why the TIF procedure is good for the treatment of GERD. Is there anything else you wanted to add or let these people that are watching know about you and your practice? If you're in the Tucson area or area, I'm not too familiar with Arizona, but I know if you're in the Tucson area, you can come and see Dr. Chiasson. But do you have any final thoughts that you wanted to share with everybody?
No, I just, my comment is that, my area of interest is in diseases of the esophagus and the stomach. I have a weight loss practice, and I also manage all conditions of the esophagus and the stomach, from esophageal cancer to gastroparesis. Do a lot of this anti-reflux type of work. If people are more interested in finding out more about me, I do have a website. It's just patrickchiassonmd.com. You're more than welcome to go there to learn a little bit more about my practice. I want to thank the folks for coming out this evening. This has actually been a lot of fun for me. I think this is something that really is a look at the future in terms of how we as physicians can communicate with our patients, especially in the era of COVID. I think we're going to be doing a lot more of this sort of online educational process. So again, I want to thank you from Endogastric Solutions for having me on, and for the patients, the folks that came out to watch tonight, thanks for your attention.
Thank you so much, Dr. Chiasson. I appreciate that. And if you're not in the Tucson or Arizona area, please feel free to visit gerdhelp.com. There's a lot of good information about the not just TIF, but GERD in itself and treatment options. So also there's a physician finder. If you're trying to find a physician in your area, you can put your zip code in and it will pop up the physicians that are doing the TIF procedure in your area. So Dr. Chiasson, I can't thank you enough for doing this and being on tonight. I know the people in Tucson, Arizona appreciate it, and so do we. Again, feel free to join us. We do TIF Talks every Tuesday evening, and have a great evening, and we'll catch you next Tuesday. So thank you very much. Have a great night.
All right. Thank you very much.
Thank you.